My name's Dr. Eunice Chen. I'm from the Department of Psychiatry, where I'm an instructor there. And my educational background, I originally did my PhD at the University of Sydney in Australia, hence the accent, and then subsequently moved to the States, where I worked for the Yale Centre of Eating and Weight Disorders, where I helped them set up their relationship with the bariatric surgery program there. And then subsequently moved to the University of Washington in Seattle to do more research on eating disorders, and then came here. I've worked here since July 2005, and what attracted me to come and work here was the amazing multidisciplinary team in surgery and also in psychiatry that I work with. John Alverdi came with a very, very strong reputation, as did Daniel LaGrange. So that was a major reason why I came here. I became a clinical psychologist because I'm interested in helping people, I'm interested in behaviour and how to change behaviour and to understand emotions and how to help people alter those things in the service of meeting their goals in life. I think if I were a client and were looking at different surgery programs that were available, I would choose the University of Chicago Center of Surgical Treatment of Obesity because I would recognise that the surgeons, the psychologists and dietitians who are here are not in it just for the money. Okay, I'll be really straight and direct with that because what I do see, especially happening in bariatric surgery, is something very sad, and that is that there are drive-through surgeries that happen, people don't get assessed properly before the surgery, and I think if I was a client, I would want to come here because I'd know that my surgeon's not really interested in that. He's really interested in how to give me the best possible outcome. What is lovely about this program, which, because I've worked on other bariatric surgery programs, is that I feel that everyone is an equal here. And so the reports from dietitians, the reports from psychologists, the reports from surgeons, they all contribute to a picture. And I think there's a lot of mutual respect that happens between all of us so that we respect each other's opinion when it comes to decision making with regards to clients. My approach to treatment and working with clients is, first of all, for most people, this is the best option for them. But at the same time, it also presents a lot of challenges as a treatment for clients because post-surgery, your life alters radically in all sorts of spheres. Everything from eating to the way you might work, your relationships change post-surgery. And so I think that's another thing for clients to recognise, and I like being able to help people through that process. I love working with our bariatric clients because they present with all sorts of interesting problems that I feel that psychology can contribute a lot to. And I think there's a lot of the things that we're trying to understand research-wise as to how to help people better. My laboratory is very interested in what sort of psychosocial variables predict good outcome in surgery. And we're interested particularly in looking at how can we help people who might not have predictors that predict good outcome. So for instance, binge eating may be a predictor of poor outcome with surgery. It may be, it's still very controversial, but we know that for many people who struggle with that, it really is very difficult to do very well after surgery. So we're very interested in helping people, say, reduce their binge eating before they have surgery so that they can subsequently do really well. The first thing is that we'll do a very, I think, comprehensive assessment and evaluation, just generally psychologically, of where you are at. This includes everything from what are your expectations of surgery, what are your motivations for surgery, what's your eating like before surgery, are there any sort of psychological problems that you might want to address before surgery, things like being depressed, having panic attacks, or just being anxious generally. Is there anything in your history that might be of importance which would mean that we want to prepare you very adequately before surgery. And then sometimes we actually refer people to more assessment, like if we think that it would make more sense to get a lot of assessment around, say, anxiety, because panic attacks have been a problem and you haven't found a treatment that works for you. We might suggest that you go and get further specialist assessment for that. We might also suggest that you organise some sort of treatment for that before you actually have surgery. Now, I also run the eating disorders clinic for adults in psychiatry, so one of the things that we might look at is whether you need further assessment for eating problems and further treatment for it before surgery. I think that for many people, because of the way surgery is often advertised, will think that bariatric surgery is, a magic wand. We wave and that's it, a person is immediately cured. And the realities are that it is an amazing tool. It is the best tool out there, I think, for obesity. But it is only a tool. It still does mean that a person has to work very hard to change their behaviour with regards to eating and physical activity and exercise post-surgery. The surgery is going to have a very powerful effect. You've got to make the best of it in terms of physical activity and in terms of eating. But nonetheless, for the rest of your life, you're going to have to make those behavioural changes. The surgery itself will not be a cure-all or fix-all. I think that it is important to go in with realistic expectations of this surgery. So this idea that surgery is going to be a tool, but nonetheless you'll still need to change your eating and your physical activity after surgery. The clients who I've seen and worked with closely who've been the most successful after surgery have actually done very well as far as physical activity, and that's something I promote with the clients that I work with closely. To me, it's not so clear if psychological factors actually predict outcome, because sometimes, for instance, relationships change post-surgery, and because of that change, we often can't anticipate that. So we can't necessarily say that that's going to be a predictor.